Well, welcome to everyone. My name's Jane Johnson, and I'm the Associate Director at DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Just before we begin, let's talk about the housekeeping rules for the webinar. Please feel free to introduce yourself in the chat and tell us where you're from. We also invite everyone to have their cameras on so we can be united as an OMM research community. If you have technical issues during the webinar, please put a message in the chat and we will attempt to solve your issues. If you have any questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. Also, we will have time for discussion and questions at the end of the presentation. Please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. And we will trim off all of our chat that we had before we started the webinar. So today is our Let's Talk About OMM Research educational webinar entitled Complementing Stroke Recovery with Osteopathic Care with Dr. Alan Yee. Alan Yee, DO, is a vascular neurologist and associate professor of neurology at the University of California, Davis School of Medicine. He received his osteopathic medical degree from Kansas City University of Medicine and Biosciences College of Osteopathic Medicine. He completed residencies in internal medicine and neurology at the Cleveland Clinic and Mayo Clinic, respectively, followed by fellowship training in neurocritical care and stroke at the University of California, San Francisco. He serves as the Associate Program Director for the Neurology Residency and Vascular Neurology Fellowship programs. As a core medical educator, he developed interprofessional and postgraduate training curricula to improve neurological care among health professionals. Dr. Yee's previous research focused on neurologic prognostication in patients with critical brain disease. His current research focuses on osteopathic examination rater reliability and the impact of musculoskeletal health, e.g. somatic dysfunction, on quality of life after stroke. Please help us welcome Dr. Yee.
Well, thank you, Jane, for that very kind introduction. And I'm going to go ahead and launch my presentation and just reconfirming that the audio and video are acceptable, I hope. I'm going to launch it from my end over here. And again, confirming you can't see my cheat sheet notes once the PowerPoint pulls up on my end.
Yep, that looks good. Thank you.
Okay. Well, gosh, it is a true pleasure, blessing, and an honor to be invited to present to this group of experts and audience, and particularly to present on a topic that's near and dear to me, and that is on how can we potentially complement stroke recovery with osteopathic management and care in a disease population that's very large with very little to benefit in the chronic phases. The only disclosure is that I've received some funding kindly from the American Osteopathic Association to support the work that I'll be describing in a little bit. Over our time together, I'll describe to you in a 10-foot or 10,000-foot level the burden of disability after stroke and the most common musculoskeletal complications that arise. I'll hopefully provide some foundation in how we in the stroke community and rehabilitation network quantify post-stroke outcomes, and in particular, the novel application of patient-reported outcomes, I'll refer to as PROs, that quantify quality of life domains relevant to stroke care. I will very briefly summarize the current state of affairs with how the osteopathic profession has documented and published rate of reliability with standard assessment metrics, such as TART criteria. And then I'll summarize our discussion together and discuss a novel osteopathic examination paradigm called The Functional Pathology of the Musculoskeletal System and its applicability towards my patient population and research. As many of you likely have cared for patients with stroke, there are two primary types, one of which is the minority attributed to bleeding that occurs within the cranial vault, whether it's within the brain tissue itself or on the surface of the brain, the latter of which we call subarachnoid hemorrhage, often attributed to a ruptured cerebral aneurysm. But the more common cause of stroke are attributed to blockages of blood vessels that lead to cerebral ischemia and subsequent nervous system tissue damage. And of course, we look and search for the underlying cause of a blood vessel blockage stroke. We're not going to talk about that today, but again, provide you broad overall understanding of the epidemiology. Stroke is unfortunately very common. There are about 800,000 strokes that occur every year, and unfortunately, this disease continues to be one of the leading causes of death in our country. In fact, every 3 minutes and 14 seconds, somebody unfortunately is dying from a stroke in the United States. And the burden of this disease on disability is substantial. It is highly prevalent, and comorbid conditions matter. So in other words, if you look at the patients who survive a stroke, irrespective of the subsequent disability, and you ask which of those stroke patients go on to have at least moderate to severe neurological disability, it's those survivors with at least 4 or more comorbid conditions that range from hypertension, kidney failure, kidney disease, cancer, diabetes, dementia, and heart failure. Having a various combination of any of these in the setting of post-stroke survivorship confers at least a moderate to severe degree of neurologic disability. That's profound. And not surprisingly, the commonest neurologic disability types are that affect our motor function, sensation, and of course, speech and language. And when you compare myocardial infarction to stroke, having a stroke triples the annual rate of disability compared to heart attacks. It accelerates the natural age-related functional decline that will occur in all of us. And unfortunately, almost a third of stroke survivors continue to have disability years down the line. What's very difficult and quite unfortunate is that less than 1 in 5 stroke survivors continue to have, or actually have very little physical activity or participate in very little physical activity after they survive. And although we very typically talk about the usual stroke-related neurologic deficits, the musculoskeletal system is certainly not immune to the complications of stroke, chronic pain being one. And the mechanisms that are hypothesized are a variety of potential contributions, but I wanted to briefly share with you a very interesting clinical trial called the PROFESS study. This study was actually a secondary stroke prevention trial testing the secondary benefits comparing 2 different antiplatelet agents. But relevant to our discussion, they actually also asked about 16,000 enrollees of this clinical trial about their pain history and subsequent post-stroke pain history, such that we learned more than 1 in 10 of these patients enrolled end up having chronic pain despite having very minor stroke deficits, which is very surprising, in that the type of chronic pain could be a variety of causes from central pain syndromes to peripheral neuropathy. But I think the punchline was that in people who survive stroke that end up having chronic pain was strongly associated with greater cognitive decline as well as functional dependency, which was very dramatic. Hemiplegic shoulder pain is another very typical post-stroke complication that affects the musculoskeletal system. I have no doubt that many of you have likely cared for this patient population. And we attribute that pain syndrome to a variety of potential causes, from bursitis, tendinopathy, etc. And it is extremely common that when people get it, about 20% will get it within the first week, and those who don't usually get it within the first year. About a quarter of people who end up having hemiparesis will get this type of discomfort, chronic disabling condition for some. When you ask, well, what degree of motor paralysis is more strongly associated with developing chronic hemiplegic shoulder pain, about a third of people with at least moderate degrees of hemiparesis or paralysis go on to have chronic hemiparetic shoulder discomfort and pain. Spasticity is another bugaboo problem that we in the nervous system world, and likely you all, care for and manage, that oftentimes medications such as baclofen, etc., are often prescribed along with Botox. But the fundamental underlying problem is that because of an upper motor neuron lesion, meaning there is a condition that affects the communication originating from within the brain or spinal cord, impairs the natural suppressive information to a spinal cord reflex, and in this case, a stroke, impairing the relaxation response and thus causing pathological heightening of the tonic stretch reflex. And the way we identify that on physical examination is that if a person has constant or tonic rigidity of an arm, that in a person that is rigid and bending and trying to flex them at the elbow, you have this constant lead pipe rigidity. That's what we refer to as a rigid limb, as compared to a spastic limb, which is velocity dependent. So if I take that same example in a person that has spasticity, and I very slowly bend at the elbow, the antebrachium on the arm, and it's very supple and soft, but when I move it very quickly, and I extend or backward bend the elbow very quickly, it creates a catch-like sensation, which is what we define as a spastic catch or spasticity. And the predictors of which stroke survivors go on to have spasticity is not who gets it early after the stroke, but it's whether or not they have sensory motor or sensory motor impairment because of the stroke. Up to almost half of patients with initial arm dysfunction go on to develop spasticity, and those destined to get it do so within the first month or so. The average time frame of when spasticity typically develops usually ranges within the first week up to 6 weeks. But again, most people go on to get the sensation and identified on examination spasticity about 1 month out from when the stroke occurred. The concept and way to quantify and measure mobility, we're not going to talk about because it is a very complex phenomenon, whether you're describing gait or picking up an object or stretching for an object with the parietic limb. And so I wanted to transition our discussion now to how we quantify stroke outcomes. And we do that by several means. And I'll go into just a little bit of granularity with the most common measurement tools that we use in the stroke community. The first is called the NI Stroke Scale Score, which is based on a neurological examination. The Modified Rankin Score is a survey-based assessment tool that quantifies one's functional independence. The Barthel Index is a more lengthy evaluation tool determining one's ability to perform activities of daily living. The Fugel-Meyer assessment tool is applied to patients with post-stroke paralysis and tracks their recovery trajectory over time. And I'll spend a tiny bit more time discussing patient-reported outcomes. I know many of you experts in the audience and room are very used to familiar with what these represent. So the NIH Stroke Scale Score is a neurological physical examination tool that summates one's degree of disability based on their neurological exam, quantifying the severity of neurologic disability. You examine somebody's visual fields, their strength, language, etc., and thus the higher the score at the summated conclusion, the greater degree of neurologic disability. The next most common way that clinical trials in stroke quantify outcome among stroke survivors is the Modified Rankin Score. This is a very simply applied scale where I sit in front of a patient and I take a history, and the scale is graded from 0 to 6, such that when I'm meeting with them, I give them a score of 0 if they survive the stroke with no symptoms at all and are fully back to baseline. The worst score is a score of 6, the ceiling, which equates to death. That if I score them with a 3, which is in the center of the Modified Rankin Score, that person has at least moderate disability, meaning they can't walk by themselves. They need some help, whether it's with a walker or with a person, and they're unable to perform all their previous baseline tasks, including balancing a checkbook, driving, those sorts of things. Again, that is a very simply applied tool, but again, you can start to guess the limitations of it. The next I'll briefly discuss is the Barthel Index. This again is an administered survey where you as the examiner sit in front of the patient and you ask them a laundry list of standardized questions and what they can perform. Can you dress and put your clothes on? Yes, no. Can you toilet? Yes, no. You get the sort of idea. The tool is skewed towards one's physical attributes and does not incorporate psychological influences of post-stroke recovery, particularly patients that have depression, which is extremely common after stroke. It evaluates the scenario in the acute and subacute phases of stroke and is less applicable in the chronic timeline of things. And then it's not very sensitive when you try to estimate milder symptoms and signs of stroke compared to those with more profound deficits. As I briefly mentioned earlier, the Fugel-Meyer assessment is a physical examination tool, but what it is mostly doing is active examination of range of motion. So me as the rater applying the FMA tool is I'm sitting back and asking the patient, okay, I want you to grab the pencil in front of you. Then I provide a grade based on what I observe they do. It is almost exclusively active range of motion testing with almost little to no passive assessment of a joint or groups of joints. The take-home message of all the preceding metrics that I defined and showed you, again, don't ask or ever assess you touching the patient, palpating, and really determining other aspects that are critical, that are part of and influence movement and how we actually get around in the world. The last important outcome that really is only relatively new in terms of stroke clinical trials, and that is PRO assessment. Patient-reported outcomes is when you administer a survey list of questions, and it's based on item response theory that has historically been used in multiple other non-neurological conditions, or non-stroke conditions, I should say, particularly revolving around pain, heart failure, diabetes, and so on. And is relatively new in terms of stroke clinical trials, where depending on how the patient answers a question, asking particular questions about domains of health, such as about their mood, their ability to move around in the world, testing for lower limb mobility. I hope that sort of drives that idea home, that based on how they respond to question one, it will flow to a different set of questions. And these have been fleshed out in what they mean. As many of you are aware, the old PROMIS scale tool is quite good. It's applied to general health, but the NIH also developed one for neurological specific conditions such as stroke. Again, this outcome measurement tool qualifies and quantifies the patient's experience and what they deem is meaningful after they've had a stroke. And in terms of the most common healthcare and quality of life domains most affected among stroke survivors, it's those, not surprisingly, domains that affect their physical function, their satisfaction with social roles. Can they go to church? And if they do, how often? Can I go to the grocery store with my family? Can I go to a ball game, or whether they can't? And it asks about qualities in the process of those. And the last and most commonly affected is those questions about cognitive capacity or cognitive function or executive function. And so using that stroke epidemiology and background and its relevance in musculoskeletal function, dysfunction, and health, how can we as an osteopathic community integrate our skill set, which is unique, to hopefully amplify their ability to recover from stroke? Now,
Dr.
my
Yee?
patient JJ gave me permission, and I want you to observe his gait. He had a stroke about a year prior to this video, where he has chronic spastic right hemiparesis. He sustained a left subcortical thalamocapsular hemorrhage a year prior to this this video. Note that his gait is very uneconomical. It's inefficient. It's slow, and he's stable-ish. But you can envision that if something jumped out in front of him, like an animal, and he were to try to reflexively respond, it would not take a lot for him to lose balance. He has chronic asymmetrical posture, motion, even anatomical changes that have occurred over time. And so using your sort of our traditional osteopathic insight, clearly his structural integrity has been disrupted, impacting how he functions and walks. But as you can see, his musculoskeletal system and physiology has adapted and compensated to those deficiencies. But how can we re-envision applying methodology from an osteopathic perspective to enhance his sort of global quality of life, not only subjectively by unifying and asking important standardized questions with PROs, or patient-reported outcomes, to quantify his experience, and also applying concurrently strict neurologic and musculoskeletal examination criteria to get a very good composite understanding of how JJ is performing in the world and how he's living. And thus really shifting away from a disease model. A lot of this is preaching to the choir, meaning his hemiparesis, in trying to figure out, well, what is the best deep brain stimulator that's going to amplify some degree of mobility? What is there a drug? Is there an endovascular approach that I can infuse stem cells? All of these are ongoing clinical trials trying to restore the hemiparesis. But really, I think what's unique is, are there other avenues that we can complement and amplify compensatory mechanisms to allow JJ to function better in the world? As I understand it to date, there are no published criteria or methodology or studies that have taken a standardized approach to quantify the degree of musculoskeletal or somatic dysfunction among stroke survivors and stroke disabled patients. Of course, there are traditional postural and structural criteria that we have all learned from school, such as the traditional Mitchell model. There are traditional TARC criteria. But again, I want to remind myself and us that much of those criteria are based on posture and structural symmetry models. It's not that those are important, but if you look at JJ, I can never reverse its asymmetrical chronic nature. And thus, when you think and when we think about somatic dysfunction and what it means in managing him and to you, I ask and challenge us to incorporate other ideas and concepts, such as, what is the musculoskeletal system's capacity? Meaning, what is the total potential ability that the MS system can perform a task and be mobile? And what is the reserve capacity of their musculoskeletal system? Meaning, what is their battery life of the musculoskeletal system's potential to generate mobility and so forth for given tasks? And thus, and again, this is quoting my mentor, Dr. Brooks, and thus really ask us to consider integrating the idea and add, well, what about efficiency or inefficient movement, and thus non-economical function, when thinking about approaching what somatic dysfunction means when I examine somebody like JJ? And I wanted to introduce the model that I have incorporated from my research and clinical practice, because it gives me a far, I think, more rich appreciation in looking at the whole musculoskeletal system's ability to function, how economical the body moves, and its efficiency of movement when performing particular tasks such as gait. It asks specific questions about efficiency and how one part of the body moves in proportion, not whether it's symmetrical or not, to other parts of the body, integrating a whole lens approach to how the neck moves to the great toe and so forth. Because as you saw in JJ, these patients that I care for in my clinical practice have permanent chronic asymmetrical movement, chronic structural asymmetry, and thus applying a rigorous methodology that can account for those changes is going to be very important. And so I think, as an osteopathic community, really thinking and asking the question for this patient population, are there ways that we can redistribute and potentially amplify the ability of his body to compensate for something that will never change, i.e. the hemiparesis, and thus requisite diagnostic tools to ask questions about somatic dysfunction, again, focusing on how inefficient somebody moves or does not, needs to be rigorous, it has to be able to account for this chronic disproportionate dysfunction that you've seen in my patient. It must offer a level and method to quantify what is inefficient movement, and it has to be a reliable methodology, and of course, a valid approach that is able to tell me, or at least get me to the truest truth of what is or is not good movement or not, so to speak. And so we talk about the concept of reliability. Again, I know there have been several discussions and presentations in the DO-Touch network, so I won't get too much into the weeds here about it. But reliability is the evaluation process that determines whether a test can perform the intended function across multiple environments over time within different populations. The idea of inter-rater reliability, or how reproducible are the results of a same test when it's performed at different locations, people, or environments, and yields the identical or similar result, as opposed to intra-rater reliability is asking how well can Alan reproduce the same result of a diagnostic test when applied when I, again, repeat that same diagnostic test the exact same way to see if I can get the same results. And I believe Dr. Degenhardt had presented this in the past. Our musculoskeletal literature accepts a reasonable threshold or level that a musculoskeletal diagnostic test achieves sufficient agreement when the value analyzed by kappa analysis is greater than 0.4. Again, the kappa analysis is a statistical methodology that quantifies the level of agreement of a diagnostic test. Therefore, a value of greater than 0.4 is considered acceptable in the body-based literature world of things. And so to contrast it and give you some ideas for physical exam maneuvers that we have used our entire medical career, how reliable are two people at identifying or agreeing upon a systolic murmur? It's pretty bad. What about the presence or absence of abdominal ascites? It's actually not too bad. How about digital clubbing? It's okay to be not terrible. And how about the famous presence or absence of the Babinski sign? It's actually not very good when you do it blindly. Asterixis. Asterixis, as a brief reminder, that is the classic liver flap in people with hepatopathy or even renal failure, when there is the action of what we call negative myoclonus, when they have a rapid drop across a sustained posture, such as during a bilateral wrist extension or backward bending. And the presence or the agreement of that is modest. And how about auscultation between providers and agreeing on whether somebody has crackles or not? Depending on the study, it's from being very poor, I wouldn't actually say fair, poor to good. And again, reminding us that in the musculoskeletal literature, a value of greater than 0.4 seems acceptable to apply as a diagnostic maneuver and test. So I will briefly review two relatively recent summative investigations of our osteopathic literature on how reliable TART changes, etc., are at identifying somatic dysfunction. And again, a value of 0.4 or greater is considered acceptable. In this systematic review published in 2017, it looked across the history of the osteopathic literature and identified 17 studies that fulfilled its criteria, summating about 400 subjects, where those providers that performed the evaluation osteopathic physical exam test, the bulk were from osteopathic medical students, and about a quarter were from graduated practitioners of mixed backgrounds, where they asked questions about tissue texture changes, asymmetry, such as, let's say, in the medial malleoli, the anterior superior iliac spines, etc. But as you can see in the numbers, only a couple or so asked for asymmetry and tissue texture changes and tenderness and so on. And the punchline in my interpretation of the results is this, that there is overall inconsistent reliability of all the tests, although intra-rater as opposed to inter-rater reliability was a little better, irrespective of the body region tested or the examiner experience over time. And a second scoping review was recently presented at the most latest DO-Touch network, so I'm not going to get into the weeds of this. They had gone through a much more robust, in-depth discussion, so I encourage you to review that wonderful recording. But the scoping review, and for those who may not be entirely familiar with this kind of analysis, it in general is sort of a descriptive overview of the analyzed information, as opposed to a critical deep dive review analyzing the data, such as in the preceding systematic review. So that's sort of the major difference. I kind of think of it as a very good editorial of some data. But in this scoping review, they found about not quite 300 papers. And of all of these papers looking at how publications described and applied somatic dysfunction, in some of these non-US publications, they did not even incorporate the language of somatic dysfunction being a requirement as part of their standard of care. And up to almost half of these publications either did not report somatic dysfunction, it was uncleared by the reviewers how they defined it, or they might have used in retrospect ICD-9 coding. and only 16% incorporated some form of the original or traditional TART criteria in documenting somatic dysfunction. So my take-home message from that publication was that there is substantial heterogeneity in what type, how, and why somatic dysfunction is collected amongst these various publications in the osteopathic literature. So again, I alluded to the functional pathology of the musculoskeletal system model, and if it's okay, because that's a tongue twister, I'll refer to it as the FPMSS model. This was published by Dr. Bill Brooks. And again, it allows for a much more a more comprehensive analysis of motion, again, relevant to my patient population and even others, and allows a method to compare proportionality of different body areas, not just symmetry or not, and it differentiates structural pathology from the important functional pathology when performing analyses. Several key requisites required when applying this rigorous methodology are that one, you must block, quote unquote, the linkage. In the example and demonstrated by an image taken from his publication, such that if you want to ask the focus question, how much available whole cervical spine range of motion testing or range of motion is present during passive cervical spine range of motion, I'm asking about how the cervical spine moves on the thoracic trunk. Therefore, I must prevent the thorax from moving, accommodating, or compensating when I apply force to right cervical side bending. So you must block linkage of these other natural compensatory or accommodating motions. The other requisite is that the bulk of the assessment is performed passively, not asking the patient to perform how much range of motion is at the upper limb, although that also is a separate set of questions that are important to ask. But when you walk through this diagnostic model, testing, let's say, cervical spine whole range of motion, I give a grade referencing against a standard population. Once I apply a grade and I tally and accumulate, examining multiple body areas in different postural contexts, I can then plot that on a graph or histogram. It allows me to profile where the most generous regions of restricted range of motion are, therefore prioritizing what areas need the most treatment in terms of OMT. And so here's an example that if you plot this patient's data elements across a histogram, where the x-axis represents the movement severity grade, and the y-axis represents the number of points that you're documenting, that in a curve that is shifted to the right, that person's overall musculoskeletal physiology would be representative of a very loose person, a limber person, as opposed to a person whose entire graph is shifted to the left. That would be more of a overall protoplasmic stiff person. So looking at this example, when I plot this person's graph, that because they score mostly in the -1 and RR reference means reference range or reference position is a more contemporary nomenclature, that what is out of the standard deviation are these -4 representing very tight restricted areas that we should probably consider treating. And so by applying this rigorous methodology of diagnosis to my clinical stroke practice, what's been a lot of fun is a couple of years ago, I'm just doing a time check, was that I began mobilizing patients with OMT. And the patient population I'm addressing are those with chronic stroke, with hemiparesis. They must be at least in part ambulatory. And the outcome measures are that I quantify based on the FPMSS model, the severity of somatic dysfunction. I'm quantifying their gait speed, as well as certain quality of life metrics based on the NeuroQual criteria. And from the early experience from this clinic, where the average age is about 54, and when I followed about 16 people who I've seen at least 2 or more visits, or I might see them every 4 to 6 weeks, that there was a significant reduction in the overall burden of somatic dysfunction when we tally all of their dysfunction together, and they walk a little faster by using the Wilcoxon rank sums statistical analysis. So because of this experience, we submitted a grant and we pursued a study that we called the Somatic AC study, Somatic Dysfunction Characterization Following Acute Cerebral Vascular Disease, where the primary objective was to assess the reliability of the FPMSS model in quantifying somatic dysfunction after people come into the hospital with acute cerebral ischemia, and the relationship of those areas and the relationship of musculoskeletal dysfunction identified during hospitalization with survivor outcomes 3 months later on. The main aims, of course, we were quantifying within 3 different populations: 20 healthy asymptomatic controls, patients who were admitted with TIA, 20 patients, and 80 patients admitted with acute ischemic stroke. Importantly, we also sought to discriminate and document the severity of somatic dysfunction between stroke subjects with and without motor paralysis, with one sub-hypothesis being that even in patients acutely hospitalized with motor paralysis, they exhibit greater severity of somatic dysfunction as compared to their non-motor disabled stroke counterparts. And then, of course, lastly, identifying the association between hospital identified somatic dysfunction and 3-month quality of life. And the high-level protocol was that for the healthy asymptomatic volunteers, the average age was 40. They underwent a first paired examination, let's say today. We had 7 raters participate in our study, 2 of which were faculty neurologist DOs, 1 faculty physical medicine rehab DO, 2 neurology resident DOs, 1 physical med and rehab DO, and the 7th rater was an MD PhD medical student from UC Davis with a background in massage therapy. And so the healthy symptomatic controls underwent a paired rating blinded assessment applying standard examination methodology today. They came back 2 weeks later and underwent preferentially repeat assessment by the same 2 providers. But because of scheduling conflicts, the subsequent raters might have changed between the 7 different people. Those that were admitted with TIA only underwent a single paired assessment within 24 hours admission. Those admitted for stroke underwent a series of paired blinded evaluations, excuse me, by 2 different providers, day 1, day 3, and day 5 over time. Each rater knew nothing about the patient's medical history other than the major admission category. So when I rated a patient, of course, I knew they were admitted with a stroke, but I did not know the neuroimaging. I was not a part of their clinical care. I did not know any other clinical information about them. Same goes for the other raters that participated in the study. And our preliminary results, I'm very, very happy to report preliminarily that we have completed enrollment of all 120 subjects, which was a huge feat, and we're about a month and a half early from the deadline. And what we've seen so far with the intra-rater reliability, that is, how well does Alan re-identify the same results in the controlled subject when I see that person 2 weeks later, that I agreed with myself, and again, all 7 of us, about 85 to 100% of the time, in being able to identify what is really stiff dysfunction versus what is relatively no dysfunction or fairly loose, so to speak. And in the stroke population, the caveat being that one other sub-hypothesis in patients who were admitted with stroke that underwent sequential examinations on day 1, day 3, and day 5 was to ask, does the musculoskeletal system dysfunction evolve over time? So that's not really a really fair assessment of whether or not I can agree with myself on day 1 versus 3, because we're also trying to identify the natural history of musculoskeletal dysfunction over time. But what we learned is that the patient's neurological disability and musculoskeletal system function don't really change a whole lot, even over the course of 5 to 7 days. And that we agree with our findings in those that were able to repeat my own or their own examinations over time. So therefore, the intra-reliability was pretty decent. And how about the inter-rater agreement between the 7 of us? Most of the control subjects were studied early in the course of the past couple of years when we started the study. And we did okay from the 6 body areas examined. So 6 body areas being the spine as a summated whole, the upper extremities, the innominates, the hip, and the hip was defined as examining motion at the femoral acetabular joint in multiple postural contexts, supine, seated only, because again, these patients are very difficult to examine. Some of these people might be almost completely hemiparetic. So they had to be able to sit up, at least in part, with a little assist, whether it be by the bedside nurse or a therapist, in order to perform the musculoskeletal examination. And so we agreed with each other a decent amount of time, except when examining the nominate and the leg. I'm happy to share with you how we perform these a little bit later on, but that's getting into the weeds. But as the study progressed over the subsequent year and a half, and we look at all 80 subjects together, we ended up achieving acceptable levels of agreement, again, reminding us that greater than 0.4, and if we had to be even a little bit more strict, greater than 0.5 levels of agreement was acceptable. The intra-class correlation coefficient is an alternative way to test rater agreement similar to kappa, except the ICC statistic is better and probably more applicable at quantifying agreement when you look at variables that are continuous, such as blood pressure or levels of range of motion quantified over an ordinal or continuous scale, such as in the case of the FPMSS model, much more granular. And we're happy to report that we achieved acceptable levels of agreement examining all of those 6 body areas. And what about TIAs? Similarly, I was very happy to see this. And this was my favorite slide, because what I was holding my breath was, out of these 120 subjects, this table illustrates the distribution of somatic dysfunction severity. Even though the grade of dysfunction for a given movement or group of joints that we're testing the motion of, we had to tailor the summated, or tailor each grade and score to a scale ranging from 0, 1, 2, and 3. A grade of 0 was loose, pretty limber. A grade of 3, it's frozen like a rusted door hinge. And if you look at the first row controls and going down the table for TIAs across the row, then stroke patients without hemiparesis or paralysis to the very lowest row, stroke patients with hemiparalysis, you can see this nice trend of worsening motor dysfunction, meaning more stiffness, as you go from control subjects, the average age being 40, and then the disease control subjects being TIA, average age was about 63, 64, or stroke average age was 67. So we tried our best to account for confounders, be it age, and we still see this very nice trend of worsening dysfunction. And so our next steps from this data that we're still analyzing are to develop a dysfunction index or somatic dysfunction index that will help us tailor and prioritize which among stroke survivors who have disability and somatic dysfunction might be good candidates for a future clinical trial that it would be a dream come true. And we're working on collaborating with scientists to correlate biomarkers to help us understand why somatic dysfunctions develop early, or this early, because again, I mentioned in the beginning, spasticity cannot be the explanation because it hasn't developed yet within days of the stroke. So this is quite a novel finding so far. And I'm going to blow by for the sake of time and not discuss physical activity unless you want to just chat about it later. But I want to summarize and say that there are protean long-term disabilities after stroke, and that incorporating patient experience matter, not just what Alan, as the stroke doctor, thinks a patient should live like. And so patient-reported outcomes, when performed standard metrics of assessment, I think make sense. Hopefully I reminded you about the benefits and the current limitations of our traditional osteopathic palpatory diagnostic tests in identifying and quantifying somatic dysfunction and their reliability. I think that out-of-the-box thinking osteopathically doesn't sound like a bad thing. And hopefully I've successfully introduced to you all a new diagnostic paradigm that we've shown good reliability and offers potentially a more valid, a method to yield more valid results when asking specific questions of musculoskeletal function and dysfunction. I have to acknowledge my long-term mentor of almost 25 years, who has been instrumental in my career and I think like a clinician and even as a research scientist. And he and I are very good friends to this day. And of course, I have to thank many of the colleagues that made this dream come true, and my other local mentor, UC Davis, Dr. Dossett, who is an expert in integrative health and is an internist, along with other participants in the study. And I'd be happy to entertain your questions. Thank you very much.
Well, thank you. I just quick few reminders as we open up the floor to all attendees for questions and discussion. If you would like to speak during the discussion, please raise your emoji hand, which is located at the bottom of the screen under the reactions menu. We ask that you briefly introduce yourself. Please feel free to turn on your camera if you would like. When contributing to the discussion, please limit microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. We will provide you with a timer to assist you in keeping track of time. After everyone has had the opportunity to make comments or ask questions, there may be additional time for comments or questions. The moderators will be happy to read questions or comments if you would prefer to type them in the chat. Please feel free to address each other's questions and comments there as well. And so I will start with a question that was in the comments from Angelique Mazzara. And this is back when you were talking about the different outcome measures. And she asked, are FIM scores, which is the functional independence measure, scores still used to evaluate functional levels in stroke?
I have not seen that, Angelique, in my experience at multiple different institutions, perhaps within the rehab and physical medicine rehab or physical therapy community. I would suspect that might be a provider population that would probably analyze outcomes if I had to make assumptions or guesses. But so I don't have any experience with that, Angelique.
Right. We also have a question from Brian Degenhardt in the comments. And I don't know if Brian, if you want to say your own question, or you want me to ask it. Okay. What do you think the mechanism of action is for OMT in stroke patients? Is OMT treating chronic musculoskeletal conditions, minimizing factors that are contributing to the deficits not directly related to stroke? Or do you think there are some central mechanisms of action related to the stroke that would make sense?
That is a wonderful and difficult series of questions, Dr. Degenhardt. And I, in my heart of hearts, believes that it's likely all the above, and that we do not yet know what central mechanisms outside of even, let's say, spinal reflexes contribute to simple tasks like locomotion. Historically, we think of gait being perhaps mostly not supratentorial, meaning very less cerebrally driven. Yes, you can control how you want to walk, but the automated action itself, we think, has a lot to do with spinal reflex, some degree of supraspinal reflex, such as within the brainstem, but of course the cerebellum, but that removes the cortex. And so what we're learning now with electrophysiological analysis, such as EEG and other cortical-based technology, they're starting to explore contributions from cortical inputs into functions like gait. So it really begs the question, and that's a part of a biomarker analysis I'm very interested in examining and asking, what cortical-based influences may contribute to to physical activity or mobility, and thus begs the question, does providing OMT provide a sensory input into the musculoskeletal and nervous system function or dysfunction? And can you affect not only peripherally how the nervous system and musculoskeletal system respond to that, but can you influence cortical-based action or network? And thus, you might wonder neuroplasticity in the context of recovery, because it's really never been explored to this degree. And so I think could it be something simple as well. If somebody has right hemiparesis, therefore they're overutilizing the left side, And therefore, maybe I'm just busting up some fibrotic lesions on the left side. They've acquired overusage of the musculature at the left hip. Therefore, in using muscle imaging, am I just sort of increasing ranges of motion at the left hip? It could be all the above. So I think those are really exciting research questions that are well worth exploring. So, anyways, I don't know exactly, Dr. Degenhardt, but I hope to search for that. But I welcome your thoughts.
Yeah, I appreciate your comments, and I wasn't anticipating, a definitive answer by no means, but to try to see where things would be heading in the future, which you did very well in describing. I think it's pretty clear to me that just using this tool to do observational studies looking at the progression of the disability of stroke over time, looking within an individual stroke patient between the affected areas versus non-affected areas, because I bet there's going to be changes going on both sides as a result of how the body's compensating for the deficits, as well as an outcome measure for interventions. So I think it's a really exciting direction. Appreciate Bill's work and rigor in developing the model, but now it's time to use the model, and I appreciate your leadership in starting that.
Thank you. I see.
I see Bill Brooks has his hand up.
So thank you, Dr. Dr. Yee, so much for this presentation and your very hard work that's led to this point in the research process. I want to add a little historical perspective for everyone and why I'm especially excited about the results that Alan has shown. Over 40 years ago, one of my primary academic motivations was the striking absence of good reliability when it was tested under at least by those standards of the time in a rigorous way at Michigan State University, where the best and the brightest in the osteopathic manipulative medicine community came together, and reliability was really, really poor. And others, including Dr. Degenhardt, have worked on that subsequently, but it's remained a real challenge because even in the studies that we've done, the clinical studies we've done where we've shown some positive benefits from OMT, reliability hasn't really been addressed. And so insofar as this breaks new ground, I think it's important for us to realize it's just the start of this. My hope is we're going to show much more robust reliability as we continue to train practitioners and do so in other settings. The model was developed in my outpatient practice with patients who were fully ambulatory, could get on and off a more or less orthopedic table. And I want to tell you that a couple months ago when I was in Sacramento and had the opportunity to watch Dr. Yee examine a subject, we walked into the room, hospital room, and my first overwhelming thought was, I can't even imagine how he's even going to examine this patient, let alone get reliable findings. I mean, the patient was a couple, 3 or 4 days post-stroke, tubes in and out of every direction you can imagine, unable to make meaningful eye contact. It just overwhelmed me that he successfully examined this patient from a biomechanical perspective. And then when I walked out of the room and realized that, okay, not only did he examine this patient, but we're showing pretty darn good reliability, it was profoundly gratifying to me. And my hope is that this is just the start of even more robust reliability that we can show that will underpin our profession's models of evaluating and caring for somatic dysfunction.
Thanks, Bill. Sorry. We do have one more question from Brian, unless someone else has a question. Would not global disproportionate, okay, let me try this again. Would not global disproportionate posture motion grade out as being more, I'm not.
Let me take that over, Jane.
Please, thank you. Sorry.
So the issue, and I've kind of thought through the questions since I wrote it, and so I'm not sure how valuable it is, but when we're looking at disproportionality, if you had a case where a person was globally affected, would that underrepresent the grading? But what I have rationalized since then, it is also in relation to what is considered a normal population. So it just would show all of those findings in the more negative zone of that, even though it's still proportionate. Is that correct, Alan?
Yeah, I would say that is true, and that's my interpretation too, Brian. What I did not spend time to, and again, I would encourage you to review Dr. Brooks's his publication, is that based on incorporating, of course, traditional osteopathic theory and concept, that what is sort of additionally novel and new is the idea of functional diaphragms, or diaphragms which are defined as regions of the body that contribute to capacity and reserve capacity that influence mobility and movement. And those are defined by specific regions throughout the body, such as the knees, the pelvic inlet, the respiratory diaphragm, etc. And so if I come across a patient that is just diffusely stiff, then where do you begin treatment? And therefore really focusing on one, if not several regional diaphragms, quote unquote, which are areas that hopefully by treating addresses parts that are influential more significantly to helping that person move overall, if that kind of answers the question with too many words. Hope I didn't butcher that, Bill.
Alan,
Oh,
this is Mary Goldman. Thank you for that, because I've been fighting with something in my brain for the last week. In a Dean's class, I quit ballet for 30 years and I've gone back and I'm taking it again. I was having a lot of trouble getting my développés, which is when you take your foot to your knee with your knee turned out. You take your foot to the other knee and then you stretch your foot into a long length so the leg is stretched long. I couldn't get the strength going. And then I was told, why don't you bring your heel forward? And I was told that will engage your core myofascia. And I said, that sounds brilliant. So I tried it and it made it very easy. What I'm trying to say is I think you just brought into why. It's because you forced the use of the diaphragm, both in the leg and in the foot.
I understand. Thank you, Mary, for that comment.
Thank you. I think we have time for just one last comment, and I believe Miriam had her hand up. So
I don't know whether this is the place. The question that I come into this with, which is not related to the methodology, and I realize the methodology has to be developed before the research can be done. I do respect that. Do we have guidelines, and where would I look at them to find out how safe it is to intervene cranially and how soon? Because to me, as a clinician who does a lot of cranial, those are the kind of questions that I have, and I know that's not going to be in the literature yet. Are there guidelines?
And I thank you for that question. As far as I know, there are no guidelines in that regard. I think
don't make it worse.
No, please go ahead. I apologize.
That's the fear, of course, is that you want to intervene, but you don't want to make it worse.
I have one quick, Angelique here, one quick request. Since Bill was in awe of your exam, Alan, can you get someone to film you examining a hospital-based patient at different stages so we can see the strategy you're using from a 5-day versus a 2-week out versus on the rehab unit?
Yes, I have videoed my patient JJ, but he's an outpatient that you saw. I certainly think that's doable. I'd have to get approval, but I'd be happy to perform that someday and provide it to Brian and et cetera if we can get that approved by the university.
Yeah, we want to see you examined. Yeah, that'd be great.
It's nothing
Thank
special.
you.
Thank you. I just wanted to provide one last comment. I know we're a little bit over to Miriam's comment. Thank you very much for that. Although there are no guidelines, I think the unique position that I'm in, I have a fairly intimate understanding of cerebral vascular disease and neurological disease. And based on at least 3 to 5 years of experience in applying OMT more systematically, I've not encountered any complications or major contraindications even for direct techniques. And in my practice, it's mostly direct and high velocity. And so we're happy to talk about it some other day. And I felt it's fairly safe.
Thank you.
And again, thank you, Jane and Dr. Degenhardt, very much for this opportunity. I'm truly, it's been wonderful.
I think, Bill, if you have a short comment, and then I will close out the session. How's that?
Yeah, we're just beginning to train Alan in cranial manipulation, but you should be aware it's radically different than what is traditionally taught. It is very forceful rather than indirect. And that's one perspective, again, require a lot more conversation. Dr. Degenhardt, if I understand your question correctly, which was that if someone was proportionally, their motion was proportionate from head to toe, how could we tell if there was a problem? And in that case, there's always an interplay with the patient's reports of how they're feeling, what they're doing, and so on and so forth. Furthermore, even with the model that I've presented in the first book, the counterstrain model, if you interpret it as a tender point as a marker of loss of motion rather than just a tender point, that provides additional nuance and insight above and beyond the basic mechanical things that are presented in the book. So there are layers to further refine that, again, require a lot more explication, but I have thought about that possibility. So
On that note, thank you.
Thank you.
Unfortunately, our time for discussion is up. Don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel, where we can actually continue this discussion in the comments section there. So watch your email for an announcement when the recording is available. Thank you, Alan, for an excellent presentation. Our next episode of Let's Talk About OMM Research will be a journal club on February 20th at 1 p.m. U.S. Central Time. Our discussant will be Dr. Arlene Dijamco. I apologize if I'm mispronouncing the name. The article is titled, Does OMT to standard of does adding OMT to standard of care help in managing anxiety? This article discussion will give our PBRN greater insight into the study being created by our pediatric special interest group on the use of OMT to treat adolescents with anxiety. So we'll see you there. Thank you for joining us.
Thank you very much.